Hello and welcome to your Harrisburg Area Community College Blended Learning EMR program. James Weber here to talk about our discussion for airway management. This is a little bit of a longer chapter, and rightfully so, because airway management is literally one of the most important life-saving skills we have, right? So it's important that we have a good working idea as to how the anatomy works and what we can do to help facilitate better outcomes for our patients. Now, to maintain life, all humans need certain things, right? Water, food, oxygen, these are necessities, right? A lack of oxygen specifically is something that even for a few minutes can result in irreversible damage and death. When I say damage, I mean brain damage primarily. The main purpose of the respiratory system is to provide oxygen. So to give it the oxygen and to remove it the carbon dioxide. That is the obligation of the respiratory system, okay? That respiratory system looks a lot like this. Now, I'm not going to go over each working part of the upper and lower airway, but it's important that you do and make sure that you're in a really good position with how a lot of this works. We'll put a couple of extra resource links on D2L for you as well. Now, in an unconscious patient lying on his or her back, the passage of air through both the nose and the mouth may be blocked by the tongue. The tongue is attached to the lower jaw, and a partially blocked airway can produce a snoring sound. Unconscious snoring patients often are a result of a blocked airway and does require some significant action. And it's a bit of a graphic on what that action might look like, right? So that closed versus open airway managed by an occlusion of the tongue and a closed versus open air passage. We have an obligation to make sure we get that area or that space behind the oral and nasopharynx, right in that joint space, opened up so that people have the ability to pass air successfully. Other parts of the respiratory system at the back of the throat, there's two passages, esophagus and the trachea. The epiglottis helps us prevent food or water from entering the airway. The airway divides into the bronchi, and the lungs are located on either side of the heart. And that's identified pretty well in a lot of these graphics you'll see in your book. Now, other parts of the respiratory system, the smaller airways that branch from the bronchi are called bronchioles. Those bronchioles end as tiny air sacs called alveoli, and that alveolar space is where that exchange of gas occurs that allows you to bring in oxygen and take away that icky carbon dioxide. It's important, right? That is a super important part of the actual respiratory system's functions. Now, this gives you a little bit of a stepped out example of how that works. Getting down into the deepest part of the lungs, right in that alveolar space where you see that gas exchange before that CO2, that carbon dioxide is excreted, right? And it gives you a pretty good example of that. Or expelled. Expelled is probably a better word. But just the same, the lungs. The lungs consist of soft, spongy tissue with no muscles. The movement of air into the lungs depends on, like we talked about in the last chapter, depends on how the movement of the rib cage, the movement of the diaphragm. When the diaphragm contracts during inhalation, it flattens and moves outward. On exhalation, the diaphragm relaxes and once again becomes dome-shaped. Contraction and relaxation are identified in this particular graphic, right? And this talks about how when that diaphragm contracts, it opens up a little bit of space to allow for full expansion of the lungs. When that diaphragm relaxes, it increases in space or increases in surface volume, removing some of that available space within the chest cavity and causing, to some extent, that exhalation. Now, airway. We're going to talk a lot about airway, breathing, circulation, ABCs. The most important part in every patient, we've got to start with the ABCs. A is for airway. In healthy individuals, the airway automatically remains open. You have the ability to manage your airway. Your body keeps that airway open because it knows it's vitally important for your ability to stay alive, right? So airway remains open. An injured or seriously ill person is not able to protect the airway and it may become blocked. You must take steps to check the airway and correct the problem uniformly. Correcting a blocked airway, we learned a little bit about in your CPR section, but it's that head tilt chin lift maneuver. That head tilt chin lift maneuver brings the actual tongue off the back of the throat and allows for successful passages of air. And take a look at that maneuver in your book to remind you. Now, that jaw thrust maneuver, we'll make sure we post a video of this on D2L, but that jaw thrust maneuver is really for anybody that you consider possible for a neck injury, right? Maybe they're not breathing because they fell out of a tree, get hit by a car, whatever it is. In that circumstance, we don't want to tilt the head back too terribly far, so that jaw thrust maneuver will open that airway without causing too much significant overexposure of the spine. And this shows a little bit of the jaw thrust maneuver. It's really difficult from these pictures to understand what they're trying to show you. We're going to show you during your lab sessions how this is done. We also went over it a bit during CPR, but we'll make sure this gets covered during that session. Checking for fluids, foreign bodies, or dentures. Potential blocks include things like secretions, vomitus, mucus, or blood, foreign objects such as candy, food, and dirt, dentures, false teeth. Also, super important to check that airway and see if you can find one of those potential blocks, right? If you find anything in there, remove it. Get that airway clear of any obstructions. If the mouth's clear, considering using an airway device. We'll talk about that shortly. Finger sweeps. Finger sweeps can be done quickly, require no special equipment. Suctioning, also available to you as well, and can be helpful to remove secretions, especially super copious secretions that really are secretions that can really get in the way of your body's ability to maintain that open airway. Suctioning, lots of different devices. There's a manual one that's super cheap. There's an automatic one, a mechanical one that's sometimes portable, right? We also have a mechanical one that's sometimes truck mounted as well. So that portable one is something you could take inside a residence or take it on a car crash, but that portable one, or that truck mounted one, is a suction unit that only works inside the ambulance, and something that's remarkably more powerful than something as small as this portable suction unit. Maintaining the airway for unconscious patients, big thing going to be continue to hold that jaw thrust position open. If a patient's breathing adequately, place them in a recovery position. Airway adjuncts, we have an oral and a nasopharyngeal airway. Those oral and nasopharyngeal airways are within the scope of the emergency medical responder as it relates to National Registry. Two primary purposes. Oral airway maintains patient airway, and it functions as a pathway for suctioning as well. We use an oral airway for unconscious patients who are breathing, are in respiratory arrest, but people who don't have a gag reflex, right? So if you're unconscious, you're not going to have a gag reflex. Even if you're taking some snoring type respirations, you'll still be able to actually get that passed. Airway adjuncts. These are some examples of some airway adjuncts, right? These airway adjuncts are pretty darn important to be successful. You just got to know how these things are placed. We're going to show you during class how those are placed. By the way, it's all going to be part of your airway adjunct module. They can be used with mechanical breathing devices. Make sure you select the proper size, and it's part of the skill drill section in your book on how to do it. And we'll make sure in class that you get some good practice with this. Nasal airways. Nasal airways used for unconscious patients and conscious patients who are not able to maintain an open airway. Not as likely to cause vomiting. Difficulty is you can't suction through a nasal airway. Just the suction tips, even the flexible suction tips, just aren't big enough to get down in the hole created by a nasal pharyngeal airway. These tend to be my airway of preference. However, both of them have benefit. Most providers start with an oropharyngeal airway unless the patient has a gag reflex, and if they have a gag reflex, utilize a nasal airway, a nasopharyngeal airway. And we'll talk about measurement actually in the book as well. We'll show you during your lab how to do that measuring. B for breathing, right? You can look, listen, and feel. Use the look, listen, and feel technique to assess adequacy of breathing. Look for the rise and fall of the patient's chest. Listen for sounds of air passing into and out of the patient's nose or mouth. Feel the air moving on the side of your face. And if you get any one of those things, gosh darn it, that patient's probably breathing. Normal adults have a resting breathing rate of 12 to 20 a minute. Most people believe that anything faster than that is pretty noticeable, and anything slower than that is also reasonably noticeable as well. Signs of inadequate breathing, noisy respirations, wheezing, gurgling, rapid or gasping respirations, pale or blue skin, and the most critical sign tends to be respiratory rest, characterized by lack of chest movement, breath sounds, or lack of air on the side of your face. Respiratory rest, by definition, is just simply somebody who stopped breathing, and lack of chest movements and breath sounds are the best symptoms you'll find of that. Causes of respiratory rest: heart attack, mechanical blockage or obstruction, vomitus, foreign objects, illness, or disease. These are common causes of respiratory arrest, but certainly not an inclusive list by any stretch. Some other good examples: drug overdose, right? Poisoning, severe loss of blood, because when somebody has a significant loss of blood, it can actually slow down the body's ability to process that oxygen and reduce the body's ability or desire and drive to breathe. Also, electrocution by electrical current or lightning. Another reason why somebody might experience inadequate breathing. How do we deal with that, right? Biggest way is going to be to assess any motionless patient for signs of breathing, for responsiveness. If a patient is unresponsive, scan their chest to see if they're breathing. So again, unresponsive, are they breathing? That's the beginning part of every assessment. So check to see if they're responsive. That's managing that alertness. And then check to see if their breathing should follow immediately behind that. Correct breathing. If you find that they're not breathing, that's a problem you have to solve immediately, right? As you perform that rescue breathing, keep that patient's airway open. Pinch the nose, take a big deep breath, blow into their mouth for about a second or so. Remove your mouth, let the lungs deflate, and then reassume that skill again, right? That's rescue breathing. Really, in EMS should be occurring with a mask or bag valve mask, ideally. Mouth-to-mask rescue breathing, common and encouraged through the American Heart Association as the primary method for single rescue or ventilations. It enables you to perform rescue breathing without mouth-to-mouth contact, right? Because there's an awful lot of folks who say, I'm not giving that guy mouth-to-mouth, and that's okay, right? It really reduces the risk, it reduces the perception of the risk, and it really allows for our primary rescuers in the first responder community to make sure they're doing the best they can at providing those necessary respirations. Mouth-to-barrier rescue breathing. These devices that you can use to protect yourself are pretty small, right? They're small enough to carry in your pocket, and they consist of a port, hole you breathe in. You get a lot of opportunities to practice that mouth-to-barrier rescue breathing, but one of the big benefits, again, is it's a method to correct a lack of breathing, and it allows you to protect yourself from disease, which is a pretty important thing. Mouth-to-mouth rescue breathing, no equipment. There's a bit of a higher chance of contracting disease, although I gotta tell you, it's not real high. Most people aren't terribly comfortable with mouth-to-mouth, especially with folks they don't know. But we need to be aware of the fact that that's a skill that could be done to correct breathing problems as well. Ideally, in the professional rescuer setting, we're looking at a bag valve mask. We place the mask over the face of the patient, make a tight seal, squeeze the bag, and that bag pushes air into a one-way valve through the mask and into the patient's nose and mouth. And as the patient exhales, the one-way valve releases the air. You will see opportunities to practice this particular skill as well, but this is just what it looks like. That reservoir, that big bag that he's squeezing, right? That bag is what contains that oxygen, and that oxygen what is being expelled through that mask into the patient's lungs. It is one of the skills that's part of your skill set as an EMR. Airway. Check for responsiveness by shouting things like, "Are you okay?" Right? As you approach a patient, "Are you okay?" If the patient's unresponsive, make sure you have EMS on the way. Place the patient on his or her back. Scan the patient for signs of breathing and check for a pulse. If a pulse is present, correct a blocked airway with a head tilt chin lift maneuver. Check the mouth for any secretions, vomitus, or solid objects. If anything's found, clear the mouth. Checked a blocked airway with finger sweeps and suctioning. Maintain the airway by holding it open and using an oral or nasopharyngeal airway. Breathing. Check for the presence of breathing while determining responsiveness. Correct a lack of breathing by performing rescue breathing or using a mouth-to-mask or mouth-to-barrier device if it's available. Rescue breathing for children. Children are smaller, and you will not have to use as much force to open their airways or tilt their heads. Give one rescue breath every 3 to 5 seconds, averaging about 12 to 20 a minute. An infant is tiny, right, and must be treated gently. So the steps for rescue breathing are a little different, and focus on those steps in the skill drill portion of your book. The most common airway obstruction is the tongue itself. If the tongue is blocking the airway, head tilt chin lift maneuver should open the airway. It might be something above and beyond that. Food, pretty common. We've had a lot of circumstances historically where a patient's airway was blocked by food. I took a guy to the hospital years ago who I'm pretty sure ate all the cheese, about 3/4 of a pound of cheese we found in his airway, right? I couldn't eat cheese for like a year because of it. Patients sometimes have obstructed airways simply because of food. If a foreign body is lodged in the airway passage, there are other techniques you can use to remove it, right? Some causes of airway obstruction, these are just some examples. Tongue block the airway, injury itself, swelling, or a foreign object. Types of airway obstruction. Biggest thing: are you choking? If the person can say yes, I'm choking, they're not actually choking. It's a partial obstruction. And in that circumstance, when somebody has a partial obstruction, encourage the patient to cough. Right? Cough forcefully, cough hard, cough as much as you can to bring that obstruction up and to clear that airway. Right? If a patient cannot speak or cough, the patient's airway is completely blocked. Whenever a patient's completely blocked, it's considered a severe airway obstruction, right? That severe airway obstruction is when a patient's unable to breathe in or out and speech is impossible. Some other symptoms: poor air exchange, right? That could totally be a symptom. How about increased breathing difficulty, a silent cough where a person's physically coughing but you hear no sounds, or a loss of consciousness in 3 to 4 minutes. Treatment involves abdominal thrusts, right? Treatment involves abdominal thrusts. Airway obstruction in an adult. If the patient's conscious, stand behind him or her to perform abdominal thrusts. To assist a patient with a complete airway obstruction, follow common steps for the Heimlich maneuver, something that we went over with you in your CPR class. Perform that cardiopulmonary resuscitation on a patient who's become unresponsive. If somebody's unresponsive, even if you think they've got an obstruction, we always revert back to CPR. Airway obstruction on a child. Tilt the head back into that neutral position. If the child becomes unresponsive, perform CPR. Airway obstruction on an infant. If they've got an audible cry, it's not complete obstruction. Continue to manage that airway accordingly with a combination of back blows and chest thrusts. If the infant becomes unresponsive, initiate 911, begin CPR, and continue CPR until more advanced EMS providers arrive. Oxygen cylinders, these things are interesting for a lot of reasons. They're stored and compressed gases at a rate of 2,000 psi and stored in appropriate cylinders, right? The portable cylinder is, it's different sizes, right? Sometimes D size, sometimes E sizes. Depending on the flow rate, each cylinder should last for at least 20 minutes. Pressure regulator, flow meter, single unit attached to the outlet of the cylinder. It can be adjusted to deliver oxygen at a rate of 2 to 15 liters a minute, right? There's a big variant. And we're going to talk a lot about how much oxygen is appropriate to deliver and in what ways we need to deliver it. That gasket ensures a super tight seal, right? Nasal cannulas. Nasal cannulas and face masks ensure the oxygen is delivered to the patient, not lost in the air. Nasal cannulas are used to deliver medium concentrations of oxygen. A face mask is placed over a patient's nose and mouth to deliver oxygen. Non-breathing masks are commonly used by emergency medical responders to administer that oxygen. Some safety considerations. Oxygen actively supports combustion, so we will need to keep flames, sparks, heat, oily substances. We need to keep it away from that oxygen bottle when it's in that process, which is a reason why they always tell the patients, don't smoke when you're on that oxygen at home. They don't always listen, and it doesn't always work out for them. The pressure in the oxygen cylinder can cause an explosion if it's damaged. Oxygen cylinders should really be kept in sturdy places, right? Those sturdy places and those sturdy carrying cases specifically should ensure that the oxygen bottle doesn't get damaged, and they have that option. Administering supplemental oxygen. Place the regulator over the stem of the oxygen cylinder and line up the pins. Tighten by securing screw firmly by hand. Turn the cylinder valve 2 turns counterclockwise in order to secure it. And this is another skill that you're going to learn pretty heavily during your actual exam. And it's interesting. Putting that oxygen bottle together is actually a skill you'll be tested on for National Registry. So you'll have your skill sheets and you'll be able to actually go through this during your lab, but it's important to know how actually setting up an oxygen bottle works. Check the gauge on the pressure of the regulator and flow meter. You'll need to adjust the flow meter to deliver desired liter per minute. And when that oxygen flow begins, place the mask or the nasal cannula on the patient's face itself. Nasal cannulas. You can only give so much oxygen through a nasal cannula. It's designed for a low level, a low flow of oxygen, about 24 to 44%, at a rate of about 1 liter to 6 liters per minute. You have the ability to adjust the liter flow between 1 and 6, and once you have it heat up to whatever liter you want to administer, then apply the cannula to the patient. A non-breathing mask is designed to deliver more oxygen to the patient than the nasal cannula, can deliver concentrations as high as 90%, right? And it's used to deliver an oxygen flow of between 8 and 15 liters per minute. Non-breathing mask should be used on patients who require a lot of oxygen. People with shortness of breath, chest pain, carbon monoxide poisoning, maybe congestive heart failure, or signs of shock, right? Signs of shock. That supplemental oxygen must be used carefully so that you and the patient remain safe, right? You'll talk a little bit in class about how to deal with oxygen safely. Pulse oximetry, right? Pulse oximetry is used. It's a tool that is used to measure the amount of oxygen saturation in the red blood cells. It consists of a sensor probe and a monitor, and it displays the percentage saturation of the patient's blood. How much oxygen saturation, how much oxygen is in that blood. In a healthy patient, that number is between 95 and 100%. Sometimes you'll read that it's between 96 and 100%, but either one, 95 or 96 is all kind of well within that right ballpark. Anything lower than 95 is definitely something where we need to consider being concerned. The pulse oximeter cannot tell you what is wrong with the patient, but it can help you. Recognize that the patient is having a problem and determine whether your treatment is helping the patient itself. The pulse oximeter has certain limitations. It will not give you an accurate reading if the patient is wearing things like nail polish, maybe they're cold, maybe they lost a lot of blood, maybe they've experienced carbon monoxide poisoning. You're not going to get an accurate pulse oximetry in those environments. There's no machine that can really replace a good, careful patient assessment, right? We should be able to look at that patient and see signs of shortness of breath, maybe they're turning blue, and other symptoms of shortness of breath well before putting on that oxygen, or well before putting on that pulse oximeter. Pulse oximeter is just an adjunct tool, not the primary way to determine low oxygenation. Rescue breathing for patients with stoma. You can place the mask over the patient's stoma and do very similar to mouth-to-mouth breathing. If a patient's chest does not rise, seal the mouth and nose with one hand and breathe through the stoma. A bag valve mask or a pocket mask device can also be used to ventilate the patient. Gastric distension occurs when air is forced into the stomach. It increases the chances that a patient will vomit. Breathe slowly into a patient's mouth and just enough to make chest rise. Dental appliances, right? Don't remove it if it's firmly attached. Dental appliances, man, they can be expensive, right? But you may get a better seal, right? You may get a better seal if that remains in place. However, if it's loose, if you pull on it and it pops right out, it may become partially dislodged. It may get in the way, right? So it's important to remove them if they're loose and leave them in place if they're not. Airway management is in a vehicle. Gosh, this is hard, but sometimes it happens, right? Sometimes that crash is bad enough that the person in that car needs their airway managed. Use the draw thrust maneuver if the patient's lying on the floor, if there's any possibility the crash could cause a head or a spine injury. When the patient's sitting in a semi-reclining position, approach them from the side and lean in through the window or across the seat. When a patient is sitting in a semi-reclining position, grasp the patient's head with both hands. Put one hand over the patient's chin and the other over the back of the patient's head. Maintain slight upward pressure and support the head and cervical spine itself. And this is an example of what that upper pressure would look like, maintaining that neutral inline position where the patient's head and neck are all kind of lined up, but still opening up the airway so the patient has a better chance of actually being able to breathe on their own. When a patient's in a semi-reclining position, grab their head with both hands, move one hand to the patient's chin and the other one to the back of the head, and move slight upward pressure to maneuver that cervical spine, just like we saw here, right? Just like we saw here. This technique has a lot of advantages. You don't have to enter the vehicle, right? Sometimes those vehicles are unsafe depending on what's going on with that vehicle, so you don't have to enter it. You can easily monitor the patient's carotid pulse in that way. The technique stabilizes the cervical spine and it opens the patient's airway. A little bit of a summary of what we talked about for this particular chapter. Main purpose of the respiratory system is to provide oxygen and remove carbon dioxide. Give it the oxygen and remove it the bad things you don't want. When it comes to patient's experiences, right? Patient experiences possible respiratory rest, check for responsiveness, then open the blocked airway using a head tilt chin lift, check for fluid, solids, or dentures, correct the airway if needed, and use a finger sweep and suction if it's appropriate. Maintain the airway by continuing to hold the actual airway open, place the patient in a recovered position, and insert the oral and nasal airway. If the airway is obstructed, right, stand or kneel behind the patient, perform a Heimlich maneuver. Administer supplemental oxygen to patients showing signs and symptoms of shock, increases the amount of oxygen delivered to the cells as well. Pulse oximetry is used to assess the amount of oxygen saturation in the blood cells because of this. So this is just a little bit of a light summary on a pretty long chapter. Make sure you really nail this chapter. It's got a lot of extraordinary information that's going to be really helpful in your practice as an emergency medical responder. Should you have any questions about any of this content, please reach out to your program coordinator. And as always, we appreciate your time, your patience, your energy, and we look forward to hearing from you at our next discussion. Have a great day.